So, a very good morning to our wonderful audience nationwide. I'm Dr. Sheldon Criado from the Medical Affairs team of Glenmark, and it's a great pleasure to welcome you to today's event on an allergic podcast titled Reshaping Allergic Rhinitis Therapy with Intranasal Corticosteroids. So, as we are all well aware, allergic rhinitis is one of the most common diseases just on a global level and even nationwide. It even affects people across all age groups, whether it is the pediatric population, the working class, or even the elderly. The therapy for the same has evolved over the years from oral antihistamines to intranasal antihistamines combined with intranasal corticosteroids and even monoclonal antibodies. To help us further understand the nuances of the same, we have with us Dr. Vijay Varat. He is somebody who needs no introduction, so I will keep it brief. He is a consultant allergist, a pediatric pulmonologist, and a clinical immunologist. He founded the Sai Allergy Asthma Eye Hospital, as well as is associated with Sahyadri Hospital and Inamdar Multi-Specialty Hospital. He has nearly 30 years of rich clinical experience. He's been president of Universal Health Foundation. He's been past president of Pune Doctors Association and is also national faculty in Allergy and Applied Immunology chapter of the IAP. He is a speaker of national repute with a number of publications in reputed national and international journals. A warm welcome to you, sir.
Thank you.
So, without further ado, we can get into today's session. So, sir, you're well aware that over the recent years, climatic conditions have changed a lot. So, have you noticed a change in the pattern of allergies as well in terms of frequency or severity?
It's a very important question because in allergy, the climate plays a very big role. And as latest last 2 years, more than 1.5% the global warming has been. And so that's why what happens is the dust increases a lot in a number of times. And when these dust particles sit on the pollens and allergens, the dust mites and the pollen's potency increases. So that's why, and again, these pollens extend for a longer period. Like previously, we used to feel like up to February, most of the pollen and all. But now we are seeing, even last year specifically, there was no gap only. Even the pollen's continuation was up to May end also. And again, then the rainy season, the molds and some grass pollens, they start. So it was completely throughout the year. So that's why the allergies has increased. And because the allergens play a very important role in allergy, any and even including the allergic rhinitis, that's why the climate change has a very important role.
Very rightly said, sir. Thank you so much. And as you mentioned that pollens tend to stay in the air for a longer period of time, is that also one of the reasons for which allergic rhinitis tends to stay for a longer period of time?
Yes.
And is there any other trend that you may have noticed with allergic
See,
rhinitis?
practically, like previously we used to say seasonal perennial, but nowadays we are seeing a lot of perennial cases. So specifically in Indian scenario, the dust mites are around 80%. Then depending on that, our diversity, last 25 years in Pune we are doing a studies. So we have throughout the year pollens. It is not that key. So only it depends on that. Some of the patients, they get a trigger most of the time during the rainy season or winter, because winter is the one where there is a lot of flowering season all. But there are in Indian scenario like Prosopis, then Magnifera indica, Magnifera, like mango tree pollens and all. They are during the summer also. So that's why even we are finding a lot of summer allergies. So depending on that, each and every patient has a sensitization to some or the other allergens. But throughout the year, we are seeing these allergic rhinitis cases.
All right, sir. And so, would you also say that the extensive use of OTC medications is another factor for prolonging the course of allergic rhinitis?
Definitely, actually, see, itis means inflammation. At present, in Indian scenario, only symptomatic management is done with the OTC drugs and all, but the inflammation is not managed. And then the precautions and avoidance measures, like how in diabetes, we always manage the sugar. The same way here, the inflammation, minimal persistent inflammation which continues, it should be managed properly. Then only the rhinitis will be controlled. Otherwise, it will be uncontrolled.
Yes, sir. And you are also well aware, sir, that the patients, the general population, have many myths in their mind regarding the use of intranasal sprays. So, sir, they may be generally difficult to convince or convincing even the parents of pediatric patients. So, how can you consider addressing this concern?
A lot of misconceptions and myths about that. Still, people they feel like that is a steroid and it will cause a lot of side effects. Last 35 years at least, still hardly 10% change is there acceptance by the people. So that myth has to be resolved. It is very safe. It is just localized acting medications. Proper use and the proper direction is important. Wrong technique will only cause the side effects. Otherwise, it's the most safest. Even about 2 years, I have used in lakhs of patients, and nasal steroids or nasal inhaled therapies are very safe. Even that's why in diabetes also now the future therapies are on inhaled therapies. So in many of the diseases, they are planning to have a inhale. Even nasal adrenaline has been now to prevent anaphylaxis attacks. So nasal treatment is very safe.
All right, sir. And would you say that there is a particular patient category or a patient subgroup that would particularly benefit from intranasal sprays?
Definitely, specifically, the seasonal exacerbations are there, and those people which have a dust triggered allergies, those benefit a lot because the nasal steroids they control the inflammation there, the sensitization pattern also, and already the because of the rhinitis, the inflammation is there, and that gets triggered by the viruses and bacteria and funguses. So the nasal steroids they control that so that the sensitization and the further inflammation and the severity of the disease is controlled very well. So it benefits to these patients.
All right, sir. Thank you so much. And how important would you say intranasal corticosteroids are in managing allergic rhinitis? And for how long can they be safely given?
Practically, I will say my practice.
Yes.
Because as an allergist, I get a lot of severe allergic patients, even about 2 years old children also. Even below that also in some of the patients, if the parents are very comfortable and they accept my experience, I have used 1 year, 1.5 year children also. Whenever they have a very severe allergic rhinitis and there is no other option rather than giving oral steroids. So it's very safe. It can be given for a longer period also. But practically, most of the patients have a seasonal exacerbations. So if you analyze that, and during the rainy season or winter, depending on the exacerbations, that time it can be given for 2-3 months. Then again you reduce it, alternate day. Then again, along with this, some simple precautions, nasal wash, nasal douching. If it is continued, in between the patient will have an interval period so that the benefit of not having a continuous therapy also can be given to the patients.
Okay, sir. Thank you for the elaborate answer, sir. And we just touched upon using intranasal corticosteroids. In which cases would you prefer using a combination of intranasal corticosteroids with intranasal antihistamines? And similarly, for how long would you consider this combination?
It's a very important because I have seen many patients, they go on using the combination for a longer period and then the tachyphylaxis happens and the tolerance develops. So it should not be that way. When in the cases where simple like intermittent or persistent mild to moderate allergic rhinitis is there, most of the patients they show a response to the nasal corticosteroids. The patients which have a moderate to severe persistent, there sometimes they don't respond to only nasal corticosteroids. There the agilastine can be combined as antihistaminic. So for a time being for 10 to 15 days, and then you reduce and then shift over to the inhaled nasal corticosteroid. Only now the rhinoconjunctivitis term has come since 2017 and 90% of the children always have a rhinoconjunctivitis. Even adolescents and adults also, many have a rhinoconjunctivitis, around 60%. There, this combination can be given for a longer period. The reason is that there, it's a nasolacrimal duct inflammation, nasoocular reflex, and the localized sensitization happens. So, if you use the agilastine, it gives a good relief for itching so that the complications of the itching and rubbing should not happen.
Okay, sir.
Yes.
So would you say for moderate to severe patients, you could consider giving the combination and then maybe stepping down to monotherapy? For example, you'll start with a combination of intranasal antihistamine and corticosteroid and step down to stay with the monotherapy. Is that accurate?
Definitely.
Okay, sir.
That's the thing.
All right, sir. And any particular precautions that need to be taken while treating asthmatic patients that have allergic rhinitis?
Children specifically, 90% of the children have underlying some or the other allergens as a trigger, or 80% have allergic rhinitis amongst that. Adults also 65 to 80% asthmatics always have allergic rhinitis. It has been found. So that should be also checked as a doctor. And then the nasal hygiene should be maintained properly with the nasal corticosteroids, so that that one mucosa, one disease, one airway, one disease is controlled very well. Not only asthmatics, as I mentioned, rhinoconjunctivitis, rhinosinusitis, rhinootitis. So it's all connected, rhinopharyngitis. And those patients also get a very good response, because recently there is a real-time data where it has been shown that the Th2 inflammation leading to the repeated throat infections, tonsils, adenoids also, it is connection with the nose only. So there also the nasal steroids play a very important role.
Thank you, sir. Thanks once again. So, if we are talking about the intranasal corticosteroids, and we have to compare the same, would you say that mometasone is as safe and efficacious as fluticasone furoate, or would you say mometasone is better, or vice versa?
Actually, practically also, and whatever the data has been shown,
Yes.
the most important is the systemic bioavailability.
Yes.
The absorption should be less. So the mometasone has been very well studied. Not only that, the compliance by the patients has been much better with the mometasone. And that is the only drug which has been used for a longer period, and the studies have been proven. Definitely,
Yes.
other molecules are also better, but I will say ki it depends on patient to patient, and at least I will request the doctors that at least start using the nasal steroids. That's the most important.
Yes, sir.
And then you select according to the studies and whatever the data is there. But definitely, practically and the evidence based, mometasone is still studied very well.
Great, sir. Thank you so much. And do you feel that any development in the intranasal devices might help to improve patient compliance?
Actually, these are the precision medicines now we are
Yes.
talking about that. And that's why not only the medication, but the efficacy of the medication depends on what type of valves are used, how is the spread at the nasal mucosa properly, not to have a septal side effects, the bitterness or the compliance, nasal bleeding or nasal fungal things should not happen. So that's the thing where now the future therapies are there, because most of the companies now are having a nasal steroids, but these technologies will improve the compatibility, then compliance by the patient and adherence to the therapies.
Great, sir. Thank you so much for your responses. We will now open the session to any queries from the audience.
Till we get a questions, I would like to sum up in a way, like allergic rhinitis is the central part in allergy diseases, and it is just not a, nose is not just a part of the face actually. In allergy, as I mentioned, the nose mucosa which is connected, and this persistent inflammation which continues with the newer sensitivities, even in spite of the localized symptom management, because many of, in our country, many of the people go for alternative therapies and all, some of the symptoms are controlled and they feel like it has been cured, but it is not a lower immunity, it is a hypersensitivity disease, and once allergy is always allergy till we don't manage it properly. So scientifically evidence based, research based therapies should be utilized, and not only just symptom wise, but the allergy should be managed with the proper allergen identification, some simple precautions, then monitor the patients afterwards also, because many of them patients are going into skin problems, food allergies, rhinosinusitis, obstructive sleep apnea, adult asthma, chronic respiratory diseases as COPD, which is the second death causing disease in India. And considering the dust which is increased because of the global warming and increase into the pollens and severity of the disease, which is already causing a lot of morbidities and complications into the patients, the scientifically the hypersensitivity should be considered in spite of the symptomatic control. The newer sensitivities continue with the minimal persistent inflammation. So to manage that, even suppose the symptoms are controlled, always get an expert advice, continue with the nasal steroids for a longer period also depending on the season. Does not matter, it will definitely helps to the patients.
Thank you, sir. So, one of the questions we've gotten is that you mentioned minimal persistent inflammation. Could you elaborate on the same?
See, I always give an example. Suppose a diabetic patient with a diabetic retinopathy goes to the ophthalmologist, he treats the diabetic retinopathy, but he will always refer to the diabetologist. So, underlying sugar into the body and the other organ involvement can be there. If it is missed, the patient will have neuropathy and the kidney damage and other complications. The same way, in allergy, it has been found that the patients have a minimal persistent inflammation into the body. So it's like a tip of iceberg. The symptoms are like rhinitis or bronchitis are like a tip of iceberg. The inflammation continues. And what happens here? The newer sensitivities are continued into these patients with the multiple pollens, dust mites and insect droppings, pigeon feathers or bird feathers, molds, and it does not show up the symptoms. And then it's like a heart attack also. Like suppose somebody has a blockage of 40%, he may not show symptoms. And somebody maybe at the age of 45, 50 has a severe heart attack when it is detected 90% blockage. The same way here, this persistent inflammation continues for many years also together. And one fine day, the patient gets a trigger because of the dust, smokes, or some lifestyle change, or some additives into the foods or something, or change in weather, and severe symptoms are there, not only from the same part, it may be from the any other body parts, or even the food allergies or anaphylaxis also, or severe drug allergies also. So that is the minimal persistent inflammation which continues into the body.
Thank you very much, sir. And we've discussed allergic rhinitis complicated with asthma or asthma complicated with allergic rhinitis. Similarly, how would you approach a patient having allergic rhinitis complicated with atopic dermatitis?
Actually, as I mentioned, allergic march. So most of the children, they have atopic dermatitis or eczema in the childhood, infancy. It is overcome, then they go into rhinitis, then it is maybe many of the children overcome it, then they go to asthma, many of them overcome the asthma, go to again rhinitis, rhinoconjunctivitis, rhinosinusitis, deviated nasal septum, obstructive sleep apnea, then adult asthma, COPD. And reverse also, some of the patients we have found that they present with the rhinitis in the childhood and then they go into adolescent or toddler eczema or atopic dermatitis. So it's all connected and the allergy continues. So these are all comorbid conditions. So that's why I mentioned we have to manage the allergy so that this should not happen. So even the children infantile eczema, 50% of them are going into rhinitis or rhinoconjunctivitis or asthma. So there is a allergic march.
Thank you, sir. And any particular diagnostic tests that you refer commonly in your practice to diagnose allergic rhinitis?
Yes, definitely. It's a clinical diagnosis always. Always look for the hidden signs like turbinate hypertrophy, deviated nasal septum, or Denny Morgan folds under the eyes, long eyelashes, wrinkling, dark circles, these rubbing things, or derriere line, cervical lymphadenopathy, posterior pharyngeal hyperplasia, halitosis, white coating of tongue, then protruded jaw or protruded teeth, upper caries teeth. These are the hidden signs and clinically. So it is always clinical. Definitely, the research has been happened that rhinomanometry, anterior rhinoscopy should be done in some of the patients, but the standardized skin allergy test should be done in all the patients. Skin allergy test, why I mentioned, because it picks up the mast cell bound IgE rather than the circulating IgE. Very few patients which have a food allergy also in these, they only may require an advanced component resolved diagnosis as a food allergen testing. But most of the patients, the standardized skin prick test can pick up these allergens. So these standardized tests can be done. Then theoretically or research based nasal eosinophil count, even the cough or the mucus which contain from the upper airway, that also can be measured with the eosinophils and all. Those are there, but practically they are not done. So these tests also can be done.
All right, sir. And you had mentioned precision medicine. So, where do you currently see immunotherapy or biologics being used for allergic rhinitis? And how practical is it in the Indian scenario?
Actually, biologics and probiotics are the future therapies in allergy management. Those patients with moderate to severe persistent rhinitis with comorbid nasal polyps or significant blockers nose affecting the rhinoconjunctivitis, very severe rhinosinusitis, or leading to the severe asthma exacerbations, where the patient is not getting control with the standardized therapies, even add-on montelukast or inhaler therapies and nasal steroids and all, then we can think about those patients which require oral repeated antibiotics or repeated steroids or parenteral steroids. There we are using a biologics like omalizumab, mepolizumab, benralizumab, dupilumab, tezekimab. These are the biologics as a targeted therapies. So Indian scenario, because of the affordability and all, It's slightly difficult, but nowadays the good part is last 2 years it has been covered under the Mediclaim. So that also can be utilized to improve the quality of life, to reduce the inflammation, to reduce the exacerbations, and to stop the further progress also. And then desensitization, allergy vaccines, allergen immunotherapy, or tolerance development is the only disease modifying therapies to stop the progress from nose mucosa to the lower airways to the systemic effects of allergies. These allergen vaccines we introduce against the dust mites, pollens, insects in a very diluted in thousands of dilution and slowly introduce as a subcutaneously or sublingually, and that built up concentration is achieved to that level where the patient, if he is exposed to the allergens, you should not develop a reaction, rather than the tolerance should be developed. Then the maintenance therapy is given for 18 months to 3 to 4 years that way. So these are the very good precise medications and which can be used to stop the progress of the disease.
Thank you, sir. Another question is, in terms of adult patients having allergic rhinitis, how comfortable are you using the combination of intranasal corticosteroids with intranasal antihistamines for short term, and how comfortable are you for long term?
Even about 6 years also I am using. As I mentioned, the rhinoconjunctivitis is very common in children.
Yes.
It is disturbing. So there we are using for 3 to 6 months also, depending on the exacerbation. Many of the patients in the winter or summer, they have a problem. Adults, so it's very safe. We have used very well. Only the technique is important. If it is not used properly, then it goes to the postnasal and it causes a lot of throughout the day bitterness and irritation and some nausea. So properly at the only nasal terminates, it should be used. It can be used for a longer period also. No problem.
All right, thank you, sir. And we'll be winding up shortly. So, in your clinical experience, sir, have you seen efficacy on par of mometasone with FF?
Yes, actually, mometasone, as I mentioned, it is very good molecule, and I have used it very regularly in most of the patients. It has shown a very good results. Even FF is also very good. I mean, both are compatible. Systemic bioavailability is lesser with the mometasone, and which has been studied for a longer period. Both are very efficacious, definitely.
All right, sir. So maybe similar efficacy, but
Yeah, yeah.
safety would be higher with mometasone.
Mometasone, yeah.
All right, sir. In 2 minutes, if at all we get any more questions, otherwise we can wind up. So for immunotherapy, sir, do you prefer sublingual immunotherapy? Do you feel it may be on par with injectable?
Actually, both the therapies 2013, we are lucky that in India only, Hyderabad, the World Allergy Organization meet was there, and there is a documented position paper of World Allergy Organization. It has shown that both are at par, though both are efficacious. Only the subcutaneous immunotherapy has been used for a longer period,
Yes.
since many years, and that's why in Western countries it is very comfortable and the people are using there. But in Indian scenario, now 90% of the allergists are using the sublingual immunotherapy, and we should be very proud that now this year the tablet form sublingual immunotherapy has come for the dust mites.
Yes.
Maybe for the pollens and all it also will come. It is very efficacious, it is most standardized, and it is very safe. It does not require any storage conditions also.
Okay.
So like a freeze or refrigeration, that's very good part. The patient can carry with them anywhere. So this type of future therapies will be really helpful to the patients.
Okay, sir. Sir, and final question. The role of intranasal corticosteroids post-surgery, like turbinate surgery or FASS, for example.
Actually, as an allergist, I don't operate,
Yes, sir.
but still patients come to me post-surgery
Yes.
with the problems. It is very efficacious because already, because of the surgery also, there is a disturbance, there is an inflammation over there.
Yes.
And this is a localized and it controls the inflammation very well as compared to the other any of the medications. And rather than giving a oral and parenteral steroids to control the inflammation, the nasal steroids play a very important role. That's why my colleagues, ENTs, they are using a budesonide respules also added on into the this nasal wash, boiled and lukewarm water, and asking the patients to use that in
Alright.
such a high dose so that the inflammation also will be controlled. So
Alright.
definitely they are useful practically.
Great, sir. Thank you so much for a wonderful session, which was scientifically rich and I'm sure has helped to educate us all. So, with that, we can close this session. Thank you very much for joining us, sir.
Thank you. Thanks a lot.